them in, and I think they're coming on in just a little bit. And here we go. So, what are we talking about today? Being double minded. So, the book of James says, a double minded man is unstable in all his ways. So, of course, that's the first scripture that I think about when I think about schizophrenia. Why is that? Because schizo, and then phrenia. So, in the olden days, before neurology separated from psychiatry, way back in the late 1800s, 1860s to 1890s, in that era, you had these people that would actually feel the brain or the phrenium, and they thought they could tell by the number of bumps on your head what kind of mental health concerns you had, or things about your life. And it was just very, very interesting. So this is where we get a lot of our current terminology. Anything that you see that says phrenium, it's basically talking about the brain. So schizo actually means split. Okay, so schizophrenia is split mind. So now you see why the first scripture that pops in my head is double minded, right? James says a double minded man is unstable in all of his ways. So that got me thinking, of course, with my Holy Ghost imagination, is the split mind or the unstable mind, the double mindedness, does that have anything to do with schizophrenia? And I'm going to tell you why I think it doesn't. So, the double minded man, when we're thinking about the book of James, is actually talking about a person that can't decide what they want to do with their life, right? They might start out one way and then they might go and do something else, right? It's really more of the person that's just kind of scattered or distracted or just can't figure out what they want to do, like I said, with their life. That's not schizophrenia. That's not the mental disorder of schizophrenia. But why am I bringing this up? And why am I saying that this is a really important thing? I'm going to do a little clip, not a live, but an actual clip, a teaching clip, where I try to do these teaching clips in 2 or 3 minutes and then share them with you so that you can share with others who might be struggling in this way. The schizophrenia split mind that phrenologists, for lack of a better term, again, this late 1800s group of people, the reason they talked about the split mind of schizophrenia is because this person in one period of their life would look completely normal, not neurodivergent. Their personality seemed to be fixed. They seemed to have a basic way of interacting with other people, very straightforward. And then there would be this period of time where they would kind of split. It seemed almost like their personality was split, right? Now, this is not going into the borderline personality disorder, but they're connected. And I'll tell you why that is in a little bit. But for the person that seemed to be split, it was like they went from during one period of their life in their young adult time, teenage time, during that time and younger, they seemed one way. And then there was a split. It was almost like the person became something different. There is a famous artist who had schizophrenia, and I have to remember the name of the artist, and I'll post it and share it later. If you know who I'm talking about, I would love for you to post in the comments because my mind is glitching on it. But you could actually see when he was much younger and he was painting, a cat looked like a cat. I see a cat, you see a cat, we all see a cat. And then as time progressed, the cat became less cat-like. First, it was something that looked like a cat, and then it was more of an abstract cat, and then it kind of looked like a tiger, and then it looked like a monster. That was basically explaining to you in artistic form what was going on in the mind of this person who did actually have schizophrenia. In one mind, the pre-mind before the illness, everything looked normal and, as we said, copacetic. After the illness, you started seeing the brain portraying things in a very different way. It clearly wasn't the same. A normal cat was no longer a normal cat. It was abstract, and then it became this monster. So for a person with schizophrenia, for them to truly have a diagnosis of schizophrenia, and I want you to really think about this, they have to have some evidence of psychosis, meaning the way that you or I would think of as normal, and I'm putting that in air quotes. We're going to change that terminology to reality, meaning that I see a certain reality, you see a certain reality. You see my fingers, I've got 5 fingers on this hand, 5 fingers on that hand. I take 100 people, I take 1,000 people, I take 1,000,000 people, I show them my hand, I show them this hand, and they would all say 10 fingers, right? 5 here, 5 here. A person with schizophrenia, if they're in a psychotic episode, might say, you've only got 3 fingers on this hand and 3 fingers on this hand, or it doesn't look like a hand. It may look completely different. That means that their version of reality is different than everyone else's version of reality. Another thing that you might see in a schizophrenia or any time a person has psychosis, we call it reality testing, meaning they're not seeing the same reality as I am. Either they're not seeing it or hearing it, or they're having some other type of perceptual disturbance. That could be a hallucination, that could be a delusion. A hallucination is I'm not seeing or perceiving reality the same way you are. Either I'm seeing something that you don't see, I'm hearing something that you don't hear. Those are just visual and auditory hallucinations. A person can also have tactile hallucinations where they feel things that another person doesn't feel. They can also have gustatory, meaning they taste things, or even have olfactory ones where they smell things that are different. Those are all types of hallucinations. Another concern for a person with psychosis is that they would have these delusions. And they can be all kinds of delusions. They may think that you're not who you say that you are, or they may think that people are trying to do things to them that really aren't trying to do things. They could have paranoid delusions, that's an example, or they could have a grandiose delusion. Those are all different types of delusions. So a person can have hallucinations, they can have delusions, but either way, we would say that there's a problem with the way that they perceive reality testing. Multiple types of psychoses. There are whole people that study this very, very much. Not my forte, but because of Mental Health History Awareness Month and then Men's Mental Health Awareness Month, I'm sharing this information because there's a point that I'm going to make in my 2 to 3 minute video that I want to exhaustively share here. And I do it in the live because it's there. You can always go to YouTube and see the lives. But then when I have my little short videos, those are either on a reel or a short or on a TikTok video. And those are things that I want to tell you where I say, hey, look, I got something big. I got something that really could be something that's a game changer. And in this case, yes, I paused because I wanted your attention. In this case, many people are often diagnosed with schizophrenia based on the wrong criteria. I'm going to say that again. Sometimes many people have been misdiagnosed with schizophrenia, meaning they did not have the schizophrenia. And you guys know what I talk about. I don't like giving labels. I like listening without labels, but we give a label or a diagnosis for the purpose of making sure that it drives treatment. Wrong diagnosis, likely the wrong treatment. Right diagnosis, hopefully we're going to get the right treatment. So it's important. But here's something that I want you to know. Black men particularly are often misdiagnosed with schizophrenia, and often they have something else. And I have seen many during my medical school years, during my residency treatment, during my time working at Unity Healthcare in DC. So many Black men were diagnosed with schizophrenia. And when I did a little bit more digging, or a colleague did a little bit more digging, more often than not, very, very sad, but most often wasn't schizophrenia. It was something else. So I'm going to talk to you about just a couple big mimickers, okay? Number one, bipolar disorder, schizophrenia, major depressive disorder, all of the major things that you think about when you think about a mental illness, OCD, all of the big ones, right? The big ones where it's not like, oh, I never even heard of that. The ones that you've probably heard of. You can't diagnose them. You can't diagnose them unless you have certain things. Every single thing, when you look at our little DSM Bible, and I love the Bible, but the DSM Bible, the Diagnostic Statistical Manual Bible for Psychiatry, that one basically says, if there's another disorder that makes more sense, you can't diagnose this. You can't say it's schizophrenia if there's another reason that makes more sense for it, okay? That's number one. Number two, it can't be because the person's under the influence of drugs or alcohol. I can't call you a person with schizophrenia and you're high on meth, or you're high on cannabis, or you're high on alcohol. I can't say it's schizophrenia, okay? That's a mimicker. That's something else, right? How many people do you know that act a little outside of themselves, or see or hear things or do things that are silly? Put in the comments. And they act like they're not in their right mind. But guess what? It's because of whatever they're using. You cannot call that schizophrenia. You cannot. Please don't do that. If you've been diagnosed with schizophrenia, but you know you were drinking or smoking or doing something else, come on now. Please tell your doctor, yeah, I was smoking or drinking when they diagnosed me. Okay, and then we can work with that. And you have to be sober for a period of time. That's why people don't like diagnosing certain things when a person is not in sobriety, because it kind of muddies the waters. Okay, so biggest one is substance induced psychotic disorder. That's the biggest mimicker that I've seen. I've definitely seen, I had a young man who was smoking cannabis, and I had a different young man who was smoking and using not bath salts. I did have somebody who was using bath salts back in the day, and he was using something else and was diagnosed with schizophrenia. And I was like, nope, can't diagnose him with this. It's because we knew his family came in later and told me, yeah, he's been high, right? And so we had to say, no, this is not schizophrenia. This is something else. So you really need to be thinking about that. So that's the biggest mimicker, is substance use mood disorder. The other one is just another axis 1 disorder. For example, one of the big ones, two of the big ones, major depressive disorder with psychotic features. You're depressed and you're hearing voices telling you to do something to yourself, or you're depressed and you're hearing voices saying, you should just, curse God and die. Life's not good. And then you're seeing dark things, dark shadows. Not schizophrenia, more than likely. Okay. I can't diagnose you till I evaluate you. But 9 times out of 10, that is a major depressive disorder with mood congruent psychotic features, not schizophrenia. Okay. And I'm glad this is resonating with some people, because again, it changes the treatment. It's the difference between a person being on an injection for the rest of their life and me giving you an antidepressant with a little bit of Risperdal or Abilify for maybe a month or two, and then taking away the Risperdal and Abilify and just keeping you on the antidepressant once the mood congruent voices go away. You see what I'm saying? There's a difference. There's a difference. Another big mimicker, which falls in the second category, is another axis 1, schizoaffective disorder. It's not schizophrenia. They're different. They're two different. We used to call them axis 1s. And I'm dating myself, but they're the big guys, right? Major depression, schizophrenia, bipolar disorder, schizoaffective disorder. Those are disorders that you really got to look between the lines and see what's going on. If they've got mood issues and they're hearing voices and other things at the exact same time, and then the mood goes away and the voices go away, but it's not necessarily depression. Maybe it's more like a mania or something, some other kind of mood disorder. Probably not schizophrenia, right? So you have to think about that. You have to think about these things, and you really need a person that knows what they're doing. I love my colleagues. We need lots of our colleagues out here, but I will tell you, the people that have actually gone to med school and have actually done a full 4-year psychiatric residency probably going to be better diagnosticians, right? Because they've been trained that way. I'm just saying that, okay? I'm not saying anything against some of my other colleagues, but I know my colleagues that actually went to med school and then did 4 years of general surgery and then did another 2 or 3 years of specialty surgery are going to be better surgeons than me. Hey, this is just a no-brainer, guys. Okay, I'm just, call a spade here. People that have been trained to be diagnosticians are probably going to be better at diagnosing. So that's why you need people that are actually going to really look at these kinds of things. Because I've seen folks that have gone to some providers that really haven't been trained very, very well. And then they've got all these different diagnoses. And I'm looking and I'm seeing like 7 or 8 diagnoses. And I'm like, whoa, pause. And then they're on like 12 medicines. Polypharmacy, too much. It's probably because they were misdiagnosed somewhere along the way, and they need a wash in terms of the diagnosis. They need a person to go in and just look at everything, see what's going on. So just my little words for thought, my food for thought as it relates specifically to schizophrenia, because that's one of the most misdiagnosed mental health disorders that I'm personally aware of, just because I spent a lot of time working in the prison system and in the community health system, and the vast majority of my patients were African-American men. And we know that they are more likely to be misdiagnosed with schizophrenia than any other group. The third one that I'm going to share with you are not so much the big axis ones, but the ones that are becoming like the sexier things right now. Like it's sexy to be neurodiverse or neurospicy, which is cool, or neurosparkly. I love it all. But the people with autism, the people with ADHD, or some other conditions. So for that, I want you to think about the fact that some of those folks, there's a reason that autism can kind of mimic a little bit of things with schizophrenia. And people sometimes get diagnosed that way. Again, I've seen folks in the jail system, unfortunately, or it's like, oh yeah, the schizophrenia. And then as I look back, I'm like, there was autism. But when the Dr. Bluler, psychiatrist, sorry to take you through this history lesson, but it's important. He had what were called the 5 A's, right? I'm not going to give all of them to you now, but it was like avolition and autism and alogia. These were all the A's to help people remember these are the symptoms that you think of, or some of the things that you think of with schizophrenia. Yes. So people often do get misdiagnosed with a lot of different things, or diagnosed with several things, because to our credit, or to kind of, I don't want to use it as an excuse, but we might see you in one period of time and you may be able to share a certain period of information. And then life happens and other things happen, and then something else happens. Bipolar disorder, look at the topic that I have on bipolar disorder. That's an excellent one, because many people get diagnosed with major depressive disorder first because they haven't had a manic episode. And you can only share about the history of what you've had. Then you have your manic episode. And then it's like, boom, I thought it was MDD and it's bipolar disorder. Very common. Doesn't mean the diagnostician is not worth, their salt. They could be. It's just that you haven't declared the symptom yet. And we can only go by symptoms because we don't have testing. But let me just tell you this about schizophrenia, because I'm getting ahead of myself a little bit. For schizophrenia, one of the A's is autism. And it's because it was that pulling into the self, into the self, that was a symptom of schizophrenia. Because a person with schizophrenia could completely just kind of pull into themselves, enter their mind, kind of have a whole conversation with themselves, live a whole life, have a whole theatrical production. For some people, I've seen it. For people that are severely and persistently mentally ill, they'll be on the street and they'll be having a whole argument with themselves. And you may or may not be involved. But for a person that's very mentally ill, you might see, right, a whole. That's part of the autism, into the self. Well, the first person, Dr. Kanner, and associates and colleagues, Asperger's as well, but for a different reason, he pulled out and started having different conversations about this. But basically, pulled out the autism from the schizophrenia pool and said, there is a group of people that the reality testing is okay, but they can get very pulled into themselves, have a rigid way of thinking, can just kind of be very pigeonholed into one set of interests, conversation, play, do everything all within themselves. The autism got pulled out from schizophrenia, and then they started looking at autism symptoms as a whole. That's where that came from, and that's the connection with schizophrenia. The reason that it can be confusing is that there are lots of external factors that can make things worse. With bipolar disorder, we tell people keep a schedule, keep your diet the same, keep your sleep schedule the same, because many of those things can throw you off and can be triggers for a manic episode. And schizophrenia is very similar. You can be told keep certain things the same, your medicines, all kinds of things like that, because you don't want to have a psychotic episode. And I've seen people who do very, very well on a regimen, and then they'll get something off. They'll forget a medicine. They'll, go on a trip and they're exposed to more sun or more people or more noise or more stressors, and that can kind of set them off. So because of those things, you want to make sure that you're keeping that in mind and also sharing that with your doctors. I've had several of my patients, a couple that I'm thinking of in particular. You guys know I live and breathe depression and mood disorders. Schizophrenia is not my forte. That's a Chuck Nemeroff or some of my other, some other famous doctors that I highly respect. But those folks will tell you that stability can be very important for folks who have been diagnosed with certain mental illnesses, because one little thing, can be the straw that breaks the camel's back and really causes people to have a hard time. And we don't want that, right? If you're doing well and you're going stable, that's great. I get very concerned about my patients when they're like, oh yeah, I'm missing medicine doses, or I'm traveling and I forgot my medicine, or this medicine is giving me side effects, so I think I'm going to stop it, or I'm going to lower it. I'm thinking, let's have a conversation about how we can safely do this. And I'm a very, very, very cautious person when it comes to medications. I want to start low and go slow when we're going up on things. And I also, when we're I'm kind of a, let's change this one little dose. That's just kind of how I am when it comes to medications and such, because, you know, people have lives and they want to live their lives to the best of their ability and not have lots of difficulties. Okay. TikTok, we're going to get ready to go. I see over here on Facebook and Instagram and maybe YouTube as well, where I am. I'm not at home. I don't know if anybody can tell. You probably can't tell where I am, but that's not a U.S. air conditioner. I'll put it that way. So because of that, I don't know what my signal is going to be like, but I did say that I was going to try to come on during the weekdays. And when signal was just really, really bad, you guys didn't see me at all, but you got to see my team and my staff share some things. So really hopeful and excited about that. So what I want you guys to do, again, put in the comments some of the things that I talked about earlier. If you've been diagnosed with something and it wasn't really what you thought it was, or you were treated for one thing and then turned out that it was something totally different. I'd love to see that. And I know that it will be helpful for some of the other folks that are watching. But also, please, 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 if you're concerned about the diagnosis that you have been given or a loved one has been given, please go to your provider, primary care provider, your psychiatrist, your mental health provider, whoever they are. Go to them and just tell them that you're concerned about your diagnosis and you just like a more thorough evaluation, okay? Or an evaluation looking at your past records. You can always, 2 thumbs up, gold star for everybody that will go back to your previous doctors and get your records. You are entitled to your medical records as long as the person's still in practice and you can get them, right? So if it's a hospital, they got to keep it for a long time. I don't know, every state's a little different, every hospital's a little different. But usually medical records, you got to go back at least, I think, 2 years for most places. Sometimes it's 5 or 7, sometimes 10. Get your medical records. You are entitled to your medical records. A doctor has to give you your records. Now, in psychiatry, we got a little bit of a special clause because we don't want to give you something that could kind of trigger you or incite you. Let's say you really do have schizophrenia and you're in the middle of a psychotic episode. I don't want to give you something or show you something in writing that's going to really make you have a hard time, okay? The truth can hurt, right? I don't always like seeing the truth, like, right? I like the truth given to me in love, but when it's not given to me in the proper packaging, it can be painful, yes. So, and not every provider, trust me, I know. I've trained with some very interesting people. Not every provider knows bedside manner, and their notes reflects that. So you may not see the most positive things, and sometimes you'll read something in a note and it's not what you think it is. If I say SOB, I'm not calling you SOB. I'm probably referring to shortness of breath, right? But you don't know that. So just note that in psychiatry, we may give you a summary. We may not give you the full note, maybe a summary. Some providers will do that, but it should at least be the basics: your diagnosis, your medications, what worked, what didn't work, overall, how you're doing, those kinds of things. Okay. So thank you for the hearts, the likes, the other things. I really appreciate that. And for those of you who are on YouTube, on Instagram, on Facebook, as always, as I said, put in the comments if you feel like things are going great for you. If they are not, again, I'm a psychiatrist, but I'm not necessarily your psychiatrist. This is your wake-up call. This is your wake-up call to reach out to your provider, bring them your medical records, and let them know what's worked and what's not worked. Okay? You guys take care and have a very blessed day on purpose.